Good evening, everybody. Welcome to another evening webinar. This one's special. For the first time, we are collaborating with the UK Renal Pharmacy Group, and I'm delighted to welcome Claire and Charlotte to join us.
So Graham had joined specifically to, just to say how great it is that we have this collaboration with the UK Renal Pharmacy Group, which are part of the UK Kidney Association. I'm really excited tonight because I always feel like I don't know enough about AKI and CKD, so I'm sure I'm going to learn a lot. My name's Helen Williams. I'm a consultant pharmacist for cardiovascular disease. I work in South London. Cardiologists are often responsible for precipitating AKI and exacerbating CKD, I think, because they're so aggressive with some of their drug therapies. So I'm sure I'm going to learn a lot from both Claire and from Charlotte. I think we're going to kick off first with Claire, who's going to take us through AKI. Is that correct?
That's correct, yeah.
I'll hand over to you, Claire.
Lovely.
Thank you very much.
Thank you, Helen. That's very kind of you. And thank you, everyone, for attending the webinar this evening. Hopefully, we're going to give you some insight into AKI and CKD, and obviously share some of the knowledge that we've got and perhaps reignite some of the knowledge that you've got in your head that you don't use very often. So, oh, no, that won't work now. Slide. There we go. Right. So I thought we'd just have a recap on what do our kidneys actually do, just so that we know what our kidneys are going to perhaps not do for us when we go into AKI. So kidneys are involved with an excretory and regulatory function. They excrete fluid and potassium, phosphate, the acid, and also drugs as well. So drugs are really important when our kidneys are not working so well. They also have a metabolic function, so they're involved in synthesizing erythropoietin, they're involved in activating vitamin D, they're involved in excretion or degrading some other hormones like insulin, and they're also involved with production of renin. And they have a physiological process as well, so they're, as I said, involved with production of renin, so they control blood pressure, various aspects of water and electrolytes homeostasis, and they're involved with the maintenance of acid-base balance. So you can see by this that what sort of things might go wrong when our kidneys fail us. So a very brief recap again, just to go over it. Simply put, the kidneys, they regulate salt and water, they remove waste products from the blood into the urine, so they produce the urine. So knowing how much urine we're going to produce will help us know whether our kidneys are working well or not. They're involved with regulating blood pressure. They create erythropoietin, so they're regulating if we're anemic, they're producing or helping the production of red blood cells. They're keeping our bones healthy, and they're involved with excreting drugs. So KDIGO is an American conglomeration that says that the kidney is a fairly robust organ that can tolerate exposure to several insults without suffering significant structural or functional change. So any acute change in kidney function often indicates severe derangement and predicts a poor prognosis. And I'll talk to you a little bit more about this as we go through. But the kidneys are quite robust, but when they fail, it shows us that actually something else is going on as well, and it does predict poor prognosis. So we're going to talk tonight about acute kidney injury and also about chronic kidney disease. And they're very different, but they can have some of the same symptoms that the patient's going to show. So AKI is a rapid deterioration of renal function. It happens over hours or days. So within 48 hours, it's characterised by reducing urine output or increasing serum creatinine. So serum creatinine is often a lag behind what's going on. So it will actually often show you what's happened a day or 2 days before, and obviously take that a little bit longer to recover as well. What your urine output is doing is a very good predictor of what's actually happening to the kidneys at the moment. So normally we would produce about 0.5 mils per kilo per hour of urine. And then as that tails off, you can actually show that the kidneys aren't working quite so well. And then when you check with the blood results, you can see that the creatinine's gone up. So it's a very good marker if somebody is unwell in hospital or at home. Looking at what their urine output is will tell you what their kidneys are doing at the moment and help you to try and decide what to do for that patient. So what is AKI? I've said it's an acute, significant but acute deterioration in renal function over hours or days. And we see an increase in serum creatinine and urea. AKI can result in a failure to maintain fluid, electrolyte and acid-base homeostasis. So the patient might become hyperkalemic or low bicarbs. All of those things can be affected if the kidneys aren't working very well. But some of the other issues that happen with CKD we don't see with AKI. So we don't see an effect in hemoglobin or calcium necessarily with AKI. AKI can then be staged. So there's different severities of AKI. We've got these staging 1, 2, and 3. AKI or KDIGO both have the same staging, and you can base that either on serum creatinine or on urine output. So there are 3 stages of AKI. First stage is 1.5 to 2 or 1.9 times your baseline, and the baseline is the lowest creatinine in the last 3 months. It can either be a change of greater than 26 in the last 48 hours, or 1.5 times the baseline in the last 3 months. Or, as I've said, a urine output reduction as well to less than 0.5 mils per kilo per hour for 6 to 12 hours. So that's important perhaps in nursing homes or in acute, very hot days to look at the urine output. An AKI stage 2 is twice the baseline, what your creatinine normally is, and a stage 3 is 3 times your baseline, or an increase in serum creatinine to more than 354, or requiring renal replacement therapy, or being anuric. So there are 3 different stages, and as you progress, the mortality increases with that. So if you have an AKI stage 3, you've got about a 50% mortality at 3 months. You're only 50% chance of making it out of hospital. But if you have a stage 1, 2, or 3, you've got a 50% mortality at 12 months. So it is a predictor of what else is going on in the body. And it's one of those signs that perhaps the patient's becoming a bit more frail and is more likely to then have further AKIs. So we have some NICE guidance that helps us know what to do. So NICE would tell us that we need to identify those patients with AKI with acute illness and at risk of AKI. So we need to look at the patients that we're looking after. Are they at risk of having an AKI? Do we need to be extra mindful if they're unwell? Do we need to be extra mindful if we give them a particular new medication? We need to investigate AKI by measuring serum creatinine and comparing with the baseline. We need to be cautious in patients that have had contrast. So those patients that perhaps come into hospital, had a CT with contrast and sent home, we need to be monitoring the blood results to make sure that they don't get an AKI. We need to perhaps then perform a urine dipstick, again, not looking for whether they've got a urine infection, but looking for blood and protein to see whether there's damage to the kidney. And that might give us an indication whether there's an intrinsic AKI occurring. We need to look at reviewing their medication and withholding any nephrotoxic medication, especially if there's hypovolemia going on at the same time. And we need to look and see whether we need to scan the kidneys. If there's no clear cause, do we need to do an ultrasound of the urinary tract to see what else is going on? Only about 7 or 8% of patients who have an AKI will ever be seen by a nephrologist. But if you have an AKI stage 3 that isn't caused by something simple like a blockage, then we need to then see, they need to be referred to a nephrologist to see what else is going on. They may require particular diagnosis that we would then need to treat. Early recognition is really important. AKI is not just a secondary care problem. About 65% of patients will come into hospital already with their AKI. So 2/3 of cases begin in the community. So it's something that we all need to be looking at. Primary care has got a crucial role to play in looking at prevention, early detection and management, as well as post-AKI care. There's a very nice toolkit on the Royal College of GPs that looks at how to monitor a patient if they've had an AKI. And there's a programme going through at the moment, which is the Renal Services Transformation Programme. That's looking at CKD, dialysis and transplant. And one of the work streams in that is AKI. And they're looking at not only in hospital, but also in primary care, what we can do to support primary care in looking and preventing and recognising those patients with AKI. Can we get something that would flag up on the system that you've got a patient that's at risk of AKI if you prescribe a non-steroidal or something to a patient with other risk factors? So there's lots of work going on to see what we can do to increase the prevention and early detection. As I've said, there is a poor long-term outcome, especially with those admitted to hospitals. It's important to know if the patient's got AKI or not. Reduced life expectancy, increased cardiovascular risk, which we'll talk about, poorer quality of life. And early detection is likely to improve prognosis. So the quicker you can detect the patient, you may only find they've got an AKI stage 1, and that means you can try and put systems in place to try and prevent the AKI deteriorating to a stage 2 or 3, and therefore reducing the mortality. And as I've said, use of electronic systems to provide alerts by pathology systems, or looking at system 1 to flag something up if you're going to start an antibiotic for UTI in somebody that's got the risk factors, may well help us to detect those patients. And the aim is to prevent admission and also prevent progression to a higher stage of AKI, because as I've said, that recovers with a reduced mortality if we can do that. AKI, even if it's a mild case, has got important clinical consequences. So if you've had one AKI, you're more at risk for not going back down to baseline and then perhaps going home with CKD. And also if you've had one AKI, you're more at risk for having another AKI. And the prognosis does depend on the clinical setting, the underlying cause and any comorbidities. And often these patients do have lots of comorbidities. You can get complications with AKI, and again, this goes along with what I've said that the kidneys already actually do. So excretory, endocrine and metabolic issues can arise. So you can be hyperkalemic. You may need to treat the patient for hyperkalemia. There may be other imbalances. You may have a high phosphate, low sodium, calcium, and doesn't often go with an AKI, but that could be, and we need to treat that as well. Metabolic acidosis, so that can be a problem that we need to treat, a low bicarb level and high potassium. We can treat those and correct that acidosis. Volume overload, again, you can get peripheral edema. A lot of these patients, I'll show you in a moment, are going to be dehydrated, but they don't have to be, and we can get volume overload if we can't get the kidneys working again. They can be uremic, and potentially if the patient requires dialysis, you can get uremia that's severe enough to the patient might be fitting, or we may need to dialyse them because they're uremic. And as I've said, you can then get an underlying CKD at the end that the patient may get left with, and then they've got an increased risk of progression to end-stage renal disease. So what are the common causes of AKI? So the most common cause is prerenal. So prerenal is a reduction in blood flow into the kidney. So that could be caused by dehydration from sepsis, or you've got the increased dose of diuretics. A reduced cardiac function, so if the patient's got heart failure, renovascular disease, and some drugs can have a pre-renal cause. Post-renal, that's affecting what's coming out of the kidney. So that could be a blockage, a bladder outflow, some sort of obstruction. The patient might be in retention. If we can get rid of the obstruction, that means we can get the flow of urine back out again and help the kidneys. It could be stones, it could be drugs. And it could be an intrinsic reason. So 80% of the causes are going to be pre-renal, so they're reasonably easy to treat. 10% is going to be a post-renal. Again, sometimes those are easy to treat as well. And 10% of the cases are the ones where the nephrologists get particularly excited. So that could be some sort of disease, intrinsic disease, so a glomerular or microvascular disease. It could be minimal change or membranous disease that we're going to have to treat with drugs. It could be a drug that's caused it. So interstitial nephritis could be caused by a drug or an infection, or could be toxins. So these are the ones that the nephrologists are going to get more excited about. So drug causes. So about 5 to 20% of AKI cases are caused to drugs. Acute tubular necrosis is the most common one, and it results from a direct toxic effect. And that could be acyclovir, it can be sporins, aminoglycosos. Gentamicin is a very good one at doing that, and we need to be very careful with gentamicin levels. Vancomycin less so now, but it still can cause that. Contrast and lithium. So all of these drugs, CNIs, are your things like tacrolimus and cyclosporin. So acute tubular necrosis is one of the most common drug manifestations. Acute interstitial nephritis is another common one, and this is a hypersensitivity reaction. So it often goes along with proteinuria and hematuria, which is the reason why we want to do a urine dip for these patients. Often the patients will have a rash or a fever, and this can take months or years to recover from, and often we treat them with doses of steroids. So this could be penicillins, allopurinol, non-steroidals, PPIs, vancomycin, can all cause an acute interstitial nephritis. And these are the ones that the nephrologist is going to get more excited about. We can get a post-renal cause, so it's usually an obstruction. That could be stones, or it could be crystallization from different drugs. Acyclovir can do that. And pre-renal, it's about reducing the blood flow into the kidney. So that could be non-steroidals, that could be ACEs or ARBs. Again, tacrolimus with very high levels can do that. And Charlotte will talk about the problems we have around things like tacrolimus and cyclosporin, and patients being treated with things like erythromycin to increase the levels. Diuretics again. So if a patient's got different risk factors and they're on an ACE or an ARB and they've had their diuretic dose increased, that can drop the volume and therefore cause a pre-renal AKI. So we need to look at these patients at risk. We need to make sure that we are identifying those patients and we know what sort of risk factors. comorbidities. Some of these we can do something about and some we're not able to. So the older you are, the more risk you are of having an AKI. If you've got CKD, if you've had a previous AKI, if you've got diabetes, peripheral vascular disease, and then if you're on other things that can be affected, so ACEs and ARBs, non-steroidals, if you're hypovolemic, if you're hypotensive, or if you're septic. And actually, even having an infection can increase your risk of having an AKI. And often AKI is multifactorial. It's not just one thing, it's a combination of things. So looking at those patients that are elderly, diabetic, on an ACE or an ARB, they get an infection and they treat them with an antibiotic, they're not eating and drinking as well because they've got an infection, they're hypovolemic, and that actually, all of those factors means that they get an AKI. And that worsens their prognosis. And each time you get an AKI, you come around a little bit less each time. So you're more likely to get CKD, you're more likely to progress to end state. So we want to do the right response. What do we need to do? We need to make sure that we eliminate the cause of AKI. So if it's dehydration, we want to hydrate that patient. And most of those patients the majority are going to be dehydrated. If they've got an infection, they're dehydrated, rehydrate them with either oral fluids if they can take it, or intravenous fluids, rehydrate them and treat them with antibiotics, and that hopefully will get the AKI to get better as well. We need to make sure that we're looking at all their different medications that they're on. We need to make sure that we avoid those medications that are going to cause worse than AKI. So the patient at risk of AKI, we shouldn't be giving them gentamicin unless we need to give it for the indication that they've got. We shouldn't be giving them a CT with contrast unless we need to do that to know what's going on. We need to then look at, should we avoid and stop the medications they've got? Withhold is a better word rather than stop, because we need to make sure that these medications are perhaps restart. The ACEs or ARBs, we need to look at them. Are they hyperkalemic? Should we be withholding those for a few days before we restart? Again, diuretics, if they're dehydrated, should we be withholding those? We definitely should be stopping the non-steroidals and stopping the metformin, and then looking at the other drugs that we may need to dose reduce, gabapentin, opioids, all those things that are going to accumulate. Is the drug going to exacerbate the AKI, or are we going to get side effects from the drug that they're on? There's one of the things we need to be careful of is if they've got decompensated heart failure when they come in. So we need to then not necessarily stop the ACEs, NARBs and the diuretics, because that will make the heart failure worse, and that will in turn also make the kidney worse as well. So we just need to be careful of those patients. And again, is the patient prescribed any medication where the dose needs to be amended in renal impairment? So you've got your patient that you're perhaps going to see in the community that's flagged up, they've got an infection, you need to see them, you need to perhaps prescribe them an antibiotic, but then look at the other drugs that they're on. Are they on digoxin? Are they on gabapentin? Are they on allopurinol? Do we need to be reducing those doses down? And then monitor the UNEs again and reassess, I said daily, but as often as you can. So it depends on the severity of the AKI, and maybe you do need to monitor the renal function more frequently. In hospital, we'd monitor it every day, but as frequently as you can, and then reassess the dosage for all those different drugs. We then need to counsel those patients on when to restart the medication. Restarting it is as important as stopping it at the beginning. But some of them we might want to avoid. So if you've had an AKI, we perhaps want to avoid the non-steroidals in the future, but we perhaps would want them to put them back on an ACE or an ARB if they've got heart failure, they've got diabetes, they've got proteinuria, all the things where ACEs and ARBs are indicated, but we want to just be mindful and then counsel them on what to do next time. So could the patient that you're about to see in primary care have an AKI? Think about what signs and symptoms they've got. Have they got a reduced urine output? Have they got a change to urine colour? So is it much darker than normal? Are they nauseous and vomiting? So are they then likely to be dehydrated? And are they thirsty? So ask your patient, are you thirsty? Ask them if you're seeing them, stick your tongue out, look and see whether they look dehydrated as well. If they're confused or drowsy, it may be an indication that they're dehydrated. And then the blood results as well. So if you've got that to go on as well, what is the creatinine? Is it more than what the baseline is? Is it more than 1.5 times what the baseline is? And do I need to think AKI? Think about the risk factors that the patient's got. I've gone through them already. Think about their age. Have they got CKD, diabetes and heart failure, etc.? Is that patient likely to have an AKI? And have they got a risk event? Are they having a trigger? So are they septic? Have they had surgery recently? So what's the patient phoning and asking to talk to you about? And if you suspect an AKI, think drugs, think about sick day rules, think about what you're going to do. Think about assessing them for whether they're dehydrated and how much urine they're passing. and think about the urine colour. It's a really nice little thing on the Think Kidneys website. Remember, healthy pee is 1 to 3, 4 to 8, you must hydrate. So that's looking at if it's very weak, you need to look at your healthy pee, and if it's very dark, you need to think about rehydrating the patient. And sometimes it can be almost as dark as looking at Coca-Cola. So we do need to be very mindful of that. And also for yourselves, when you're looking at those people, do you need to refer it to the GP? Are you really worried about the AKI? Have they got stage 3 AKI? Are they really dehydrated? Are they not coping and being well at home? Do you need to refer them to be either admitted or to the GP? So we need to think about those patients that we've got that are at risk. Do we want to try and prevent them getting an AKI? I've said that there's a mortality associated with an AKI. It's also looking at that. Those are the patients with more comorbidities. They're perhaps frailer. We want to think about our sick day rules, okay? Think about the information. There's lots of information on the Think Kidneys website, all about AKI and about CKD. It's where you'll find the medicines optimization toolkit to help you think about the different medicines. Think about the patients you've got that you might see in a care home. Think about their fluid balance. Think about care plans, especially in this hot weather. We've had some really hot weather recently. Did we think about making sure that all of our patients are really well hydrated and drinking well? Again, the heat waves, we shouldn't be getting those, should we? But I think we might get a few more. Think about the risk. Think about the risk. Is there a risk of AKI? Think, has my patient had a trigger? And think about their kidneys. Okay? So the risks of sick day guidance. So sick day guidance is something that's been talked about an awful lot. With my kidney hat on and waving my kidney flag, I want everybody to be off their ACEs and ARBs and diuretics if they're at risk of an AKI. So if the patient has got is not eating and drinking properly, I would want them to stop their ACEs and ARBs for 48 hours to protect their kidneys from getting their AKI. But there are potential harms. Has that patient got decompensated heart failure? Do we need to be careful? If they're on it because they've been previously hypertensive or they're diabetic, then withholding it for 48 hours is not going to do them any short-term harm. And if they're dehydrated, they're likely to be low blood pressure anyway, so taking it off is going to help them. But if they've got decompensated heart failure, we just need to be careful. We need to be mindful if we've got a potassium, we want, the hyperkalemic, we'd stop it. But other than that, we just need to be careful. So think about those patients. Think about development of hypertension if you're going to stop it. So get the patient to monitor their blood pressure, okay? Think about reduced adherence to treatment. So again, it's how you word it to the patient. Don't tell them to stop it. Tell them it's going to damage their kidneys. Tell them to perhaps withhold, because while they're unwell, it's going to not help their kidneys while they're unwell. It helps their kidneys when they're well, but when they're unwell, it doesn't help them. So to withhold it for that particular time. They may overinterpret the advice and stop it. So again, it's about having that conversation with the patient, making sure they know what's going on and making sure they know to restart it when they get better. And titrating the drug back up again. So if you have stopped it and we want to retitrate back in again, you want to make sure they get back to the dose that they were on before, because that was the dose that was helping. And again, it's all about counselling. It's about telling the patient, empowering them to do something about it, but making sure they understand why they're doing it, that they're doing the right thing, and that they know to seek professional help at the right stage. Okay. So advise the patient that to speak to their heart failure team or to speak to their diabetic team. It's the heart failure patients that are particular trouble with stopping them. So make sure they've got a plan from the heart failure team, and equally making sure that that planning they know what to do. If they've been told to stop, make sure that they tell the heart failure team that they have stopped, and somebody can be monitoring them and telling them what to look at. Okay, so thinking about nephrotoxic medications. So nephrotoxic is a rather strong word. Many medications are thought of as nephrotoxic, but they're not. So there's very few medications that have a direct toxic effect on the kidneys. Several have a potential to impair the renal function under circumstances. So I've said it's a multifactorial issue. So if the patient's hypovolemic, because they've got low blood pressure, they're dehydrated, they're not eating and drinking properly, and they've got an infection, then some of these medications are going to have a compounded effect on the kidneys and cause a problem. But it's not necessarily a nephrotoxic. They're a medication with nephrotoxic potential, I suppose, is what we want to do. And then also think about all the medications that are cleared via the kidneys. So they've got the potential to accumulate during an episode of AKI. The same applies to CKD, which Charlotte's going to talk about in a moment or two. But if your kidneys aren't working very well, those medications that are renally excreted are going to accumulate. And then we need to think, do those medications have a toxic effect? So are they having a neurological toxic effect, or a toxic effect on the bone marrow? Are they going to make so penicillins, if you accumulate those, are perhaps going to make the patient fit. But if there's no actual toxic side effects, then we perhaps don't need to worry about reducing the dose of the drug. But for those that do have a toxic side effect, then we would want to be reducing the dose. And think about the patient's renal function when we're dosing all of those drugs. Okay, think about the renal offending medications and make sure that we've dose adjusted for the patient's drugs that they've got now. So this is just saying it again, but in a slightly different way. Three main types of problems. So it's the effect of renal fluid electrolyte physiology, the change in side effect profile when the renal function is reduced, and the direct action on the kidney. So in an AKI, we're just thinking about that medication that's actually accumulating. But if you're thinking about CKD, some of the other processes are changing. If the patient's uremic, they're perhaps nauseous, they're not going to absorb it very well. If they've got lots of fluid on board, then they perhaps have a boggy gut, in which case they're not going to absorb medications in the same way. So it's about thinking about all the physiology of the patient, and some of them have a direct effect on the kidneys. So you might say, why do I need to do a medication review? So we want to actually protect our patients from getting an AKI. We want to eliminate the possible cause. So the medication that they're on may be the cause. We need to think about when the AKI started, what else happened. Is the medication the cause? Is it causing a risk of AKI? And is it a contributory factor for that? And then we want to avoid inappropriate combinations of medication in the context of AKI, reduce adverse effects, ensure that the dose of prescribed medicines are appropriate for the level of renal function at the moment, and ensure that all medications applied are clinically appropriate in view of the AKI and comorbidities. And again, we want to make sure that we can suggest alternatives. If a non-steroidal in the non-heart failure patient is not appropriate, what else are we going to do for their blood pressure? Questions to ask: which medication should be suspended? Which medication should not be suspended, which is equally important? And which medication should be used with caution? And should I be using any alternatives? So this is just looking at it in a very similar way. We need to be reviewing those medications. Are they taking any of these medications? It's not an exhaustive list, but the ACEs, the ARBs, diuretics, metformin, non-steroidals, all of those things, and SGLT2 inhibitors, which Charlotte's going to talk about. Think about the antihypertensives. If they're hypotensive, we need to be stopping those, whether they're nephrotoxic or not. Dropping the blood pressure is going to be nephrotoxic. Check about contrast media. Then dose adjust. So dose adjust every medication the patient, or think about dose adjusting every medication the patient's on. Does it need an adjustment? Think about calculating the creatinine clearance, making sure that we're dose adjusting correctly for all those medications that are going to accumulate. And again, look at the toolkit on the medicines optimization and the think kidneys. And we need to monitor and follow up. Look at the U&Es, assess the patient. Do we need to do some TDM on the different drugs? Be sure that we restart the medication and educate the patient about what's happened. So this is just looking at restarting the medication. Look at the original medications they were on. Why were they on it? When should it be restarted? How and if? And should it be discontinued completely, like non-steroidals, and avoid them to use it at all? Transplant patients, we would tell them to avoid non-steroidals completely, and those with CKD we would as well. Look at contraindications. Think about restarting as soon as clinically reasonable, and review the patient in a holistic manner. Is that drug needed or not? Think about the blood pressure, and it's an opportunity to rationalise the medications. A lot of these patients are going to be frail. Do they need those medications? Okay, and I think I'm going to hand over to Charlotte for CKD. Thank you, Charlotte.
Good evening, everyone. I'm going to give you a whistle-stop tour of chronic kidney disease because it's quite a big topic. So I like this cartoon because we are obviously very concerned with potassium, but there is a bit more to it than that. So chronic kidney disease is the worsening, progressive and irreversible loss of a patient's kidney function over months to years, potentially leading to dialysis or transplantation, or even death in those patients who choose not to have treatment for it. So there's about 3 million people, in the UK with CKD, and as the population's aging, these numbers are increasing greatly. And the groups that are especially at risk of CKD are those with diabetes, hypertension, previous AKI, as Claire said, and cardiovascular disease. So first of all, you will have all seen the different stages of CKD, 1 to 5 as the creatinine increases. But also, it's also very important to look at the amount of albumin in the urine, because this is a really good measure of how damaged the kidney is. So if there is protein leaking from the kidney, it means that there is an issue with the kidney's structure, and the more protein that's leaked means that there's more damage to the kidney. And with a higher creatinine and a higher protein leak, you get increased progression to end-stage kidney disease. And obviously, if you've got kidney damage, these patients need to be investigated more. So as you see, the red boxes are those patients who are very high risk of progressing to end-stage kidney disease, whereas the green ones, they may have some creatinine increase, but it might be that their progression is very slow. Can you go to the next slide, please, Claire? So proteinuria is a very big thing, and that's why we like people to have their urine dipped so that they can see what's going on. So it's normal to have a small amount of protein excreted in the urine. Albumin is the most common protein leaked from the kidney, but obviously there are other proteins as well. We like to measure ACR, so albumin to creatinine ratio, because that's the most sensitive way of detecting low levels of protein in the urine. This is more widely done in primary care. and secondary care. We're actually not very good at doing ACR, and we usually measure PCR, which is protein to creatinine ratio, which is a little bit less sensitive, but in someone who's leaking a lot of protein, really doesn't make that much difference. Right. So as we all know, creatinine is produced continuously in the muscles, but the amount depends on decreases with the age, and also it's to do with muscle mass. It's excreted by the kidneys, so obviously if your kidneys aren't working so well, you're going to have lower level of high level of creatinine in the blood. So it's a surrogate marker of kidney function. But it's on its own, it doesn't tell you a great deal amount about someone's kidney function, because the reference range is quite large. And if you don't know anything else about the patient, of someone with a creatinine of 60, they could be really good renal function or not. So you need to know a lot more about the patient. What it is useful for is looking at trends, and especially with AKI, there's usually automatic alerting systems on most ICE or PATH results. So it's useful for identifying AKI in some patients. So we all remember Cockcroft and Gault from university. So it's a good surrogate marker of GFR. It's used a lot in clinical trials, and a lot of drug dosing is done on this. Obviously, you do need to use the most appropriate weight for the patient, which I think people are often a little bit unsure about which weights to use. So if someone's BMI is more than 25, ideally you should use adjusted body weight. If someone's got a normal BMI, then use the ideal body weight, and if the BMI is low, you use their actual body weight. And this is what we use, but it's not widely used by medics. Next slide, please, Claire. So whenever creatinine is measured, eGFR is always calculated as well. So the calculation that you see most often is the MDRD equation. So this takes into account creatinine, age of the patient, sex, and ethnic origin to some extent. So, and this gives us GFR based on a averaged normal sized person, but obviously lots of our patients aren't normal sized. And it's good. It's not validated in older people, children, people with low or very high body masses. And originally, this calculation was validated in Caucasians and African American population, as well as those who, between the ages of 18 and 70. So it's good, but it has got limited validations. So there is now a new, newer EGFR calculations, which is CKD AKI, and this has been reported more and more systems. And this is thought to be, it's meant to be more accurate, especially for older patients and those who don't have, so the other one was validated for those for creatinine clearance less than 60. This is validated for lower and higher GFRs, but it's taking a while to get it rolled out. But this will be probably more accurate when it comes into wider use. Okay, next one, Claire. So if we're looking at different patients, so we have a young bodybuilder on one side versus a little frail lady with a low body weight. So you can see their creatinine's the same, but the creatinine actually doesn't tell us a lot without looking at the patient factors. So obviously Mr. DG is probably an average weight, for probably a higher weight, obviously large muscle mass, whereas Mrs. G little, probably very low body mass because she's 75. So if you calculate the EGFR for the patients, Mr. GG has an EGFR of 95 and Mrs. G only has an EGFR of 45. So then if we look at their creatinine clearance, so Mr. GG has a normal renal function and Mrs. G has a pretty low CKD stage 3. So often with drugs, it doesn't matter too much, but those drugs with a narrow therapeutic window, we really need to make sure that we know patients' renal function before we prescribe it to make sure that they're getting the right dose, especially things like antibiotics. We need to make sure that they get enough to treat them, but enough to cause toxicity, or things like digoxin, where it really makes a difference. Okay, so NICE produced this really good guideline on assessment and management of CKD. It covers pretty much everything. So if you would, if you're interested in CKD, or if you've got a particular patient and you want to look something up, this is a really good reference to go and look at. Just to pick it out, lots of this management can be done in primary care, but there's a few things that lots of patients you really need to refer to a nephrologist, such if they've got a 5-year risk of reaching end stage of more than 5%, so red in that table that I showed you earlier, an ACR of more than 70 or an ACR of 30 and hematuria, an EGFR reduction of more than 25 or 25% or 15 mils per year, because these patients are fast progressors and they're going to end up on dialysis unless there's significant intervention. Or someone who's got a family history of genetic CKDs, such as polycystic kidneys or renal artery stenosis. So this is just to remind you that the kidneys do all these things. So if your kidneys are not working properly, you probably need support in almost all of these areas, okay? So the main aim in these CKD patients is to reduce the progression of CKD, but the biggest cause of mortality in these patients is cardiovascular disease. So we really need to make sure that their cardiovascular disease risk factors are minimized and treated as best that we can. So we need to get their blood pressure under control. They need primary and secondary prevention with statins. They need antiplatelets for secondary care, for secondary prevention, although some of these patients are higher risk of bleeding. So we just need to think about the risk factors. And I'm going to be talking about SGLT2 inhibitors as well. So hypertension is such a problem in these patients. first of all, fluid balance is a really important issue for these patients. Some of these patients may be fluid restricted. Lots of them will need dietitian involvement to give lifestyle changes about weight. Lots of these patients are obese, and they are not the easiest patients to treat. They often end up on lots of medicines, and they may need several antihypertensives to control their blood pressure. The blood pressures that we aim for is 140/90 generally, but obviously if they've got diabetes or proteinuria, they're higher risk, and so we aim for a lower blood pressure. So we use all sorts of antihypertensives. Just to know, if someone needs 4 or more antihypertensives and are not able to maintain the target levels, then they probably need to be referred to a nephrologist for specialist treatments. And we use things like moxonidine and other medicines for resistant hypertension. Okay, so this is just to show that basically for diabetic patients and non-diabetic patients with a significant level of albumin in the urine, we start ACE inhibitors. So I know that some people worry about starting ACE inhibitors in these patients because of the risk of hyperkalemia. And also we know that someone's eGFR is likely to take a little hit with ACE inhibitors. If the creatinine increases by, or the creatinine clearance decreases by less than 25%, when someone starts an ACE inhibitor, we would just recheck it after a couple of weeks. If it was decreased by more than that, they would need to be investigated for other causes. But ideally, these patients need to be on the highest tolerated ACE or ARB to help prevent long-term renal protective. Oh, okay. Okay, now we're coming on to the SGLT2 inhibitors. All right, this is going to be really big topic for lots of people. We're going to see lots of people started on this. So these are sodium glucose co-transporter 2 inhibitors. So they work by reducing the absorption of glucose in the kidneys, which is and so you excrete more glucose in the urine, and which also causes osmotic diuresis. Can you go to the next one, please, Claire? So there have been these 2 big trials that are a real game changer. So Credence looked at canagliflozin. It looked at renal outcomes in patients with type 2 diabetes and GFR between 30 and 90, and a significant ACR. These units are different to the units that we usually use, but it is a significant ACR. The trial was stopped early because of the significant results. It's lowered the risk of cardiovascular disease, death, MI, and stroke, and significantly slowed the risk of progression to end stage. So it potentially prolongs the time to end stage renal disease, so ending up in dialysis, by 15 years. So it's really significant. And then the DAPA-CKD study looked at dapagliflozin versus placebo in CKD patients with an eGFR between 25 and 75 mils per minute, with or without diabetes, with an ACR, a significant ACR. Both these studies, these patients are on max dose of ACEs or ARBs. And the primary outcome was composite decline in eGFR of more than 50%, end stage kidney disease, or death from renal or cardiovascular events. So if you look at the results there's such significant results: 39% reduction in progression to end stage kidney disease, 29% reduction in cardiovascular mortality, 31% reduction in all-cause mortality. So these trials have produced such significant results that you know, we could keep people off dialysis, people have better quality of life, reduce cardiovascular issues. So, and we know that there are a lot of people with, you know, EGFRs within these ranges that the studies did and would benefit from these treatments. So there is a nice TA out for SGLT2 inhibitors, looking at diabetes and CKD. Obviously, there's quite a lot of crossover between these two patient groups. So there's a nice TA on dapagliflozin, it's TA 775. So basically, people are eligible for treatment with SGLT2 inhibitors as an add-on to ACE or ARBs, unless the ACE and ARBs are contraindicated, with EGFR between 25 and 75 mils per minute, or more than 30 if it's using canagliflozin, and an ACR of more than 22.6 milligrams per mole. So you will be seeing a lot more of these because so many people will be eligible for treatment. There are some issues with treatments, such as patients would need to be counselled carefully on sick day guidance, as Claire went through. There are increased risk of genital infections due to the glucose being excreted in the urine. But there are lots of patient information leaflets out there. So have a look if you have patients who are going to be started on this. I think you're going to see lots in the future, and I'm sure there'll be lots of questions on this, but we can go back to them. Other things that patients with CKD have a real issue with is renal anemia, because as your kidneys start to fail, you produce less erythropoietin and you end up being more fluid overloaded, especially in the gut, so you don't absorb iron so well, so you end up being iron deficient as well. So lots of patients need help with EPOs such as EPREX or RNS or Neuracomin to maintain their hemoglobins, and also may need some IV iron as well to help produce red blood cells. This is mainly done in secondary care, and there's often renal anemia teams associated with each renal unit. So if you do have any questions, or if you have any patients on it, do contact your local renal unit. That we have to be careful with these patients, that we have to keep their hemoglobin between quite a narrow range. We don't want it too high, because otherwise the patients are at increased risk of strokes. And there is a new class of drug on them just been the nice TA for it, which is HIF inhibitors. Roxadustat is the new one that's going to be on the market. It's not going to be you may not see it because it'll probably be secondary care to start with, but these things might change in the future, because instead of being subcut injections like the ESAs, this is an oral tablet, so which will be great because we won't have to get district nurses to do the injections for our CKD patients who need this if they're not able to do it themselves. Phosphate binders is another thing that you may see for renal patients, because patients can't, if the renal function isn't great, they don't excrete the phosphates so well, and they have issues with mineral bone disease and end up with high phosphates. So these patients are usually counseled by dietitians, and they are asked to follow a low phosphate diet, but it's not that easy for the patient to get a varied diet with all these restrictions, so they often do need phosphate binders, which they take with each meal. Sometimes they do cause GI side effects, so and there's a big pill burden, so patients aren't always that keen to take them. So this is calcium acetate is the first line phosphate binder that we use. If they don't tolerate it, or if they've got high calcium anyway, we probably use sevelamer. And there are some other options if those two aren't tolerated, such as lanthanum. But these, you probably won't see these very widely. All right, potassium binders. So this is another new thing that you may see. Obviously, we're trying to use ACE and ARBs because they're so good at protecting the renal function. So, but obviously there is an issue with hyperkalemia. So there's a new nice TA for potassium binders. So basically, this is to be used with ACEs and ARBs to keep their potassium down, so that we can use the maximum doses of ACEs and ARBs for these patients. It's recently got a nice TA, so will be more widely available in primary and secondary care. Very briefly, acidosis, you'll see patients on sodium bicarb because we're just trying to correct the acidosis. Basically, if you have a renal patient who is known, CKD 4, 5, talk to your renal unit if you've got any questions. They're probably quite closely monitored. When you're prescribing new drugs for patients, make sure that you start low and titrate, because they're more at risk of side effects, and just consider the tablet burden in these patients because there's lots of polypharmacy for them. All right, let's skip on to the next one, Claire. So actually skip on to the next one because I really want to talk to you about this very, very briefly. I do a transplant clinic. We have most immunosuppressants are prescribed by secondary care, but occasionally they are done by primary care as well. There are lots of different brands of things like tacrolimus. They are not interchangeable. Patients always are counseled that they must stick with the same brand. So please ask the patient if you're not sure which brand they're on, they will know. And interactions with this, there are lots of interactions with tacrolimus, especially clarithromycin and erythromycin. We have lots of issues with transplant patients getting AKI because they're prescribed clarithromycin or erythromycin in the community. So please watch out if you have a transplant patient or someone who is on tacrolimus. Please watch out for interactions for them. Thank you. I think that's everything. There's lots of references here if you'd like to have a look.
That was brilliant. I learnt loads. We should be able to get these slides off you and pop them on our website.
Yeah, that's fine.
Is that okay with you guys?
Yes, of course.
Fine,
Yeah.
yeah.
Great. Well, we've got loads of questions, and I have been given a bit of permission to overrun a little to make sure we get to ask as many as we can. And some of these things you've covered, but I don't think it hurts to just repeat briefly. So I'm going to aim for a quick fire.
Okay.
And as I say, some of you will have covered already, but do just re-emphasize the key messages. So first one I had is, as kidneys are responsible for activation of vitamin D, is there any point in prescribing vitamin D in renal deterioration?
Yes. Yes, because they can still be vitamin D deficient, so you could check a vitamin D level. We would often use alpha calcidol in anyone with CKD because we know that they're not activating the vitamin D. But these patients can be deficient in cholecalciferol as well, so we often use them in combination.
Calculating creatinine clearance. Well, you went through, and someone else has asked about this, about when do we use actual body weight versus ideal body weight versus adjusted body weight? Any just further reinforcement of those messages? And one particular question that came is, what about DOACs?
Use creatinine clearance. Go on, Charlotte.
So basically, it depends on the BMI of the patient. And so if you've got someone who's overweight or obese, you'd use adjusted body weight. If they're got a normal BMI, you use ideal body weight. And if they've got a low BMI, use their actual weight. I'll leave the DOAX for you, Claire.
Yeah, you use your creatinine clearance to calculating DOAX, and there are calculators available like MD Calc. There's an app that you can just use, and it plugs in height and weight and everything, and will give you the range of creatinine clearance. So that's always a good app to use.
And ACE, ARB are renoprotective, but at what point should we be thinking about stopping? And is there any rationale in stopping if they're renoprotective?
So there is a rationale if you're elderly and frail and you're likely to drop your blood pressure and fall over. You're looking at, so if you're just thinking about the kidneys, you're trying to prolong the time to end-stage renal disease. So without being ageist and frailties, if you're old and frail, you may not get the benefit of having them, and your risk may outweigh the benefit. So we would perhaps stop them in the elderly patients that are likely to fall over and drop the blood pressure and have a problem, and a fall is going to be more damaging to them. But other than that, if there's no quick change in renal function, keep going with the ACE or the ARB.
Great. And then I think what I heard from the presentation, in heart failure patients with AKA, you might have to temporarily withhold some of the renotoxic drugs like the diuretics and the ACE, but the aim should be to get them back on as soon as possible.
Yeah, and we work closely with our cardiologists, particularly if you're hyperkalemic, you need to stop the ACE and ARB. If you're not hyperkalemic, then maybe you perhaps want to reduce the dose down a bit, because they are very beneficial in heart failure. And
obviously the aim is to optimise them back up to their original doses if they can tolerate that.
Yeah, and that's often a problem, isn't it? But that's what we need to be aiming for, is to titrate them back up again.
And what about transplant patients? You touched on transplantation at the end. Do you still do all the CKD staging? Do we initiate all the drugs like DAPA and ACE, etc.? Patients who've had a transplant?
We do, but it's usually done by a transplant team. They're not usually seen in the community. They're usually, as someone's transplant fails, they may be seen more often by the transplant team, but also advanced kidney care team. So they're usually kept kind of within secondary care. But yes, we do similar things for them.
Great. You touched on sodium bicarbonate. Is the monitoring all done by nephrology? Should primary care be looking at the bloods and doing any dose adjustment? Patients prescribed sodium bicarbonate.
So yeah, I think primary care should be looking. It depends on how often the patient's been reviewed by the renal team. Often if the patients are conservatively managed and are never going to end up on dialysis, they may have a plan, they may have an action plan that is then fed back to the GP, and then all the monitoring needs to be done and titrating within primary care.
Yeah. And another one that's come up is about sick day rules, and how there's quite a lot of variation as to how well communicated they are to patients and how well they are sort of utilised in different areas. What's your experience around the sick day rules and their implementation across primary care?
Again, it varies, doesn't it, on what's wrong with the patient and why they're on their ACE or the ARB, and they're often not very well communicated. I think there was a big push a few years ago about communicating that out to the patients. We've certainly got leaflets and cards that all our diabetic patients got that were on ACEs and ARBs, and all our renal patients got. But I don't know, that it wanes and goes, doesn't it? Sometimes it's flavour of the month again, but we do try and counsel everybody on it.
But it's certainly something that as pharmacists we could really be trying to get message across, and also not just to the patient but across the wider healthcare teams, I guess, because often people just aren't thinking about it.
No, I mean, we empower patients to do it. We try and empower the patients, and then they come in, or we're looking after them, and we don't do it. We don't tell them to stop them. So we need to be doing the same as what we're empowering the patient to do.
Mm. If the ACR is raised and the potassium, would you avoid ACE?
Depends how raised the potassium was, but no, probably not. Well, you can use other things as well. So you can use diltiazem, very good at reducing protein leak. So it depends what their potassium was and whether they'd had an increase in creatinine with an ACE or an ARB in the past. You can also use a potassium binder.
Yeah, exactly.
I guess look at diet. I mean, I knew from our heart failure clinics that patients thought, I need to be really healthy now, so I'll eat a ton of tomatoes and lots of citrus fruit and maybe 6 bananas a day, and then we wonder why their potassium shot through the roof. So diet's also important.
Diet's very important. Think about what potassium is in, what things potassium's in. And we had a problem with around COVID. People stopped eating apples and things, and they started eating bananas and oranges. and suddenly their potassiums were going up. I had a few patients in clinic who, oh yeah, well, I'm eating bananas and oranges because I can then peel it and not touch it, and nobody else has touched my fruit that I'm eating. So that was a problem. But yeah, you need to think about the diet.
Any reason to monitor creatine kinase in AKI?
Only if the patient's had a long lie and you're worried about rhabdo. Other than that, we wouldn't routinely monitor it now.
And are ACEs and ARBs generally renoprotective in CKD, or is it just when there's the presence of proteinuria or albuminuria?
It's the protein leak. So if we say generally, but it's to do with protein leak. A lot of the patients that we do see have got proteinuria though, so you need to watch for that. But it reduces the pressure within the kidney, and that reduces the amount of protein that's leaked out.
So would you start it sort of prophylactically before they show signs of any protein leak, or do you wait to see it in the urine and then offer the ACE-ARB? I think is the question.
Well, if I knew there was CKD, so for the polycystic kidney patients, we would use an ACE and ARB first line rather than something else, because we know they often have proteinuria. But if they've got no protein leak at the beginning, I would still use an ACE and ARB first, yes, because it will protect them in the long term.
And in terms of repeating ACRs after the initial check, when should you be doing it? I guess it might be related to how raised it is, but are there specific timeframes you would normally recommend repeating the ACRs?
Probably once a year when you're doing looking at kidney function or something like that. I mean, often the patients that we're seeing, they've got high proteinuria, and therefore we're monitoring it to see whether the disease is coming back or not. If you've got, but probably once a year is probably enough. You probably don't need to do it more often than that.
And any reason for doing an ACR in someone whose EGFR is greater than 90?
If they're diabetic, yes. If you think they've got
the comorbidities to see if there's other reasons for doing it.
Yeah.
Another transplant one, probably for you, Charlotte. How would you manage transplant patients with AKI on tacrolimus, as clearly it can't be stopped due to potential rejection?
No, obviously. So we wouldn't stop. Well, it depends on the reason for the AKI. If they've got AKI because someone's given them clarithromycin and their tacrolimus level is horrendously high, and that's why they've got AKI, we would obviously stop the tacrolimus for a few days until it's back in range. But we wouldn't just stop the tacrolimus and unless we knew the cause.
There was a question in the chat about the SGLT2s and the previous sort of contraindication around EGFRs less than 45. Obviously now we have recommendations in CKD, and I guess that's going to potentially cause a bit of confusion. People used to not use it for diabetic patients if the EGFR was low, but now we're saying actually in CKD there is an advantage. And I guess that just reflects the emerging evidence base, doesn't it?
Yeah, and I think they don't work. So you think what you're using it for. If you're using it for diabetic control, you're using it to lose glucose through the kidney. Once your renal function isn't working so well, you've lost that mechanism. But there's another mechanism that's protected for CKD. So you're no longer using it for sugar control. You're using it to prevent end-stage renal disease and cardiovascular death. So there's a different reason for doing it. So yes, they're quite safe right down to onto dialysis. But don't monitor the renal function when you start it. So when you start an SGLT2, you expect it's a hemodynamic change. You expect a reduction in renal function. So don't look for at least 4 to 6 weeks, and then it will have stabilised out. Otherwise, you'll see the drop and you'll stop the SGLT2, and it's not in the benefit of the patients long term.
So although the diabetic indication for SGLT2 says you shouldn't use them when the EGFR goes below 45, if they've got CKD for that indication, even if they're diabetic, they can continue to have the SGLT2. Just a point of clarification that's come up.
Yes, but you may need to give something else to control the diabetes.
Yeah, yes, because it's not going to have that effect on the blood glucose. If a patient is on RNS, then has a stroke, ischemic stroke, is this now contraindicated?
Depends why they had the stroke. If they were hypertensive, then you probably wouldn't want to go back on it until the blood pressure is controlled. But we have stroke patients who have had, we have RNS patients that have had strokes.
we'd carefully monitor the RNS to make sure their hemoglobin was within the target range. We wouldn't want to let it go high. But yes, I think they could continue with it.
And statins in renal transplant patients for prime prevention. Do you do that?
Secondary prevention, but not primary.
Not
generally.
primary. Not like you would.
It's not just because of transplant. If they had other issues, but
okay,
similar to the general population.
Do CVD and CKD benefits of SGLT2s improve with dose titration, or do they just need to be on whatever starting dose?
It's a stat dose. If you've got CKD, you don't increase the dose of the SGLT2s. With DAPA, it's a flat dose of 10 milligrams, and CANA you can't increase to 300 if your creatinine clearance is less than 30. So less than 45, sorry, but 30 to 45 you've got to be to start it. So yeah, it's a flat dose. Don't increase it.
There is a controversy arising within the chat box around the DOACs because many places, including where I work, we say use actual body weight unless they are severely obese. And I think you need to look to find out what your local guideline is around DOACs, because it does differ in different areas. So it is tricky. In the studies, they used actual body weight, but they didn't have obese people in the studies. So it makes it very difficult to draw conclusions. So worth finding out what your local guidance is, because there isn't a sort of national recommendation. And another interesting thing that Robin's put in the chat is around Q-risk scoring, because Q-risk at the moment, NICE says that anyone with CKD stage 3 or more should go on a statin for prime prevention. Q-risk 3 actually has CKD in it, stage 3, 4 and 5, and we found quite a lot of patients, if you do the score on Q-risk 3, it doesn't put them in the cohort that would be offered a statin of risk 10% or above. So I think we're waiting for an answer from NICE on that, because NICE have not endorsed Q-risk 3 yet, and most of the GPIT systems still have Q-risk 2 and an assumption that anyone with CKD will get a statin, if regardless. So I think we will get an answer from NICE next March, April, but we'll know what they're going to say hopefully by when they put out their consultation. That will make life a lot easier for us all.
Yeah.
I'm going to have a look through your slides, and I learned lots and reminded myself of lots, because I haven't worked in an acute setting for a long time and haven't seen a lot of the, especially the AKI and some of the more specialist CKD work. But that was really brilliant. Loads of questions. Everyone's still here listening in, despite the fact that we've run over. Well, so thank you very much.